Now, decision making in brachial plexus birth palsy for now surgery, as we have already discussed, it depends purely and purely on clinical examination. All the investigation that we get done, like radiology or EMG NCV, whichever is preferred, only helps us in planning the surgery. They don't help us in deciding whether to operate or not. So that is one point which is very important. And why it is important to know which roots are involved and what is magnitude of injury, why you need to clinically assess each and every muscle individually, because it has prognostic value. More the number of roots involved, the prognosis is little less. Again, when lower trunk or C8, T1 are involved, the amount of result that we are going to get will be little less than what we are going to get in now surgery involving only C5, C6 or C5, 6 and 7. And again, getting an MRI and other investigations done, EMG, NCV done, it helps us in planning the treatment. Now, I'll come back to one slide that we had discussed in previous webinar. There are 4 types of morphological injuries that happen to brachial plexus: neuropraxia, axonate masses, neurate masses, and avulsion injury. Now, I have pointed arrow at axonate masses because, that will guide us to an extent why we wait for a longer period in many cases. Like, 90% of roots would have neuropraxia or axonate masses. Only 10% would be rupture neurate masses or avulsion injury. Neuropraxia usually recovers by 3 to 6 weeks or starts to recover, while axonate masses takes around 6 months, at times 9 months for recovery to begin. So that is one of the reason why my concluding slides would be based on. Again, this is another way of taking it. Avulsion is usually intraspinal, while stretch injury and rupture usually occur outside the vertebral body. Now, what are the common fallacies in clinical examination that a newcomer can face? Many times elbow flexion occurs in pronation, but if you see the biceps, it's not contracting, it's flabby. So don't take it as elbow flexion when you are grading your or charting your power. Then, many times you check shoulder abduction. The child puts extremity in forward flexion, which is due to pec major, which occurs quite well up to 90 degree, and then the limb falls backwards, which commonly when we are beginner, we may fail to assess. Then again, when you are checking elbow flexion, shoulder abduction and forward flexion simultaneously, after 45-50 degree of forward flexion, the elbow will just fall on the chest. This is not elbow flexion, that we have to understand. And many times, we are holding the forearm and checking the hand function. The child is crying and moving. Your pressure on forearm muscles will make contractions of finger in flexion. This is not hand function that we want to see. Whenever you want to check hand function, stabilize shoulder and elbow above the forearm and check the hand function. Now, when to operate, as Professor Alan Gilbert said, he is very clear. At 3 months, if there is no biceps, no hand function, go in and operate in a complete palsy. While in incomplete, at 3 months, check for biceps and wrist extensions. If there is no biceps at 3 months, he goes in and operates. So that is his way. To an extent, it is right, because many times when we wait, there will be partial recovery. And when we operated 9 months, that function which we have gained will be lost and will be starting from zero, which may not be acceptable to some of the parents. So this is rational thinking, I would say. But again, the timing has always been an issue. As Maulin already said, 3 months, 6 months, or 9 months. What Gilbert says, Kawabata says, or Professor Howard Clark and Peter Waters says. And the techniques are consistently changing. Outcome comparison at present is little difficult. Uh, we should go back to 1999 paper of Peter Waters. 43% of kids without biceps at 3 months, out of that 38% recovered biceps at 6 months. So if we would have operated all those kids at 3 months, we would have operated 38 cases, probably, which would not have required any surgery. But is there any major outcome difference when you operate at 3 months? I think we can wait till 6 months, and the rest of 5 patients we can always operate at 6 months. So that is nice paper, and I would second that thought. Now, another way of seeing it is, if it is total avulsion, Horner syndrome, or both, at 3 months, no recovery, go in and operate. Otherwise, test score at 3 months. If the score fails, like many people follow HSCMS or Toronto score, whatever you follow. If the score fails, go in and operate at 3 months. If it passes, evaluate at 6 months. If there is no further progress, you should go in and operate at 6 months. But if you see there is progress, then you should wait for 9 months and check for cookie test at 9 months. If cookie test is failed by the child, then you can operate at 9 months. But if the child passes the cookie test and shows a very feeble shoulder movement, then that is also an indication of nerve operation for shoulder muscles. So grossly or broadly, we have divided our strategy into two main groups. One, at 3 months, panplexopathy with or without Horner's, but no significant improvement. We go in and operate. Another is second group, where we wait till 9 months and check for cookie test. If the child fails, then we go in and operate. This is a broad strategy, and obviously in between is the gray zone, which we may fill up in selected cases. Now, where does the investigation fit? As per choice of consultant, as we have discussed, you can get an EMG NCV done or an MRI done. This rarely guides us to decision making whether to do nerve surgery or not, but it is very helpful in guiding us to what surgery we want to do. Okay, because MRI can guide us which number of roots are avulsed, how many roots are intact, and the level of injury in the roots. While when we are doing EMG NCV, if we get a normal sensory conduction but absent motor conduction, it means that it is an avulsion injury of that particular root. EMG NCV is required also when there is doubt of co-contractions. Most commonly, before nerve surgery, the co-contraction we are worried about is biceps and triceps co-contractions. And then there are fallacies associated with all the investigations. In child, while doing EMG, the electrode may get displaced and give wrong findings, which is a possibility. MRI many a times can show, discuss many times, the child moves, and we may get signs of root injury, which on table we may not see. There, this can go against our idea of evidence-based diagnosis and medicine. And that's why it's very important that if your EMG or MRI findings do not correlate with your intraoperative findings, specifically take the intraoperative photographs. As such, you should take intraoperative photographs in all the patients. And this is the sort of MRI that Dr. Trushi was talking about. Not only pseudo-meningocele, but the exiting nerve roots should also be seen. Now, whenever we talk about nerve surgery, we should also talk about which are indicators of poor prognosis or little less prognosis. One is Horner's syndrome, which suggests lower trunk avulsion, a possibility, means C8 and T1 involvement or avulsion of it specifically. Diaphragmatic paralysis, because when diaphragmatic paralysis is there and it's not recovering, you may need to do a diaphragmatic plication or another surgery before you embark on nerve surgery, and you don't take intercostal nerves when there's preoperative diaphragmatic paralysis. Multiple root avulsion injury, more than 3 roots are avulsed, it will give poor prognosis. Multiple level injury, it's not common in opsadic palsy, it's more often in adult brachial plexus injuries. And late presentation, or after 9 months to 1 year presentation. Now, when should we do delayed nerve surgery? One is obviously if the child presents late. Whenever there is doubt in clinical diagnosis along with the investigations, like biceps and triceps co-contraction may be there, which we may not be in a position to exclude before surgery. When we need to do tendon transfer for shoulder and nerve transfer for elbow flexion, like you are getting very good elbow shoulder function but not a good elbow flexion, then you may go in little late. This is in case of C5 C6 injury. Now pre-operatively, just to brief up, slings and splints are required, regular physiotherapy whenever possible, emotional rehabilitation of parents and preparation of parents with a realistic goal, what result we are going to get and we may not get after what surgery we have done, and explain about the long duration of post-operative care that is going to take place after the surgery. So my conclusion is timely intervention in plant plexopathy is a prerequisite to avoid long-term disability. Nerve surgery many times forms platform for number of secondary surgeries or rebalancing surgeries which are going to take place in future of the child. Many times for the child, nerve surgery may not be the last surgery, and there will be many more surgeries that will be required after the nerve surgery. Thank you.